assessment. This is just a quick and dirty way to get a very baseline amount of information. Passively, I'll take them in a hip flexion. See where the range of motion is, how their end feel is, if there's any pain, pinching. If there is, you want to find out if it's in the front, inside, outside, and that can help dictate where you are. All these positions that we're testing, we want to make sure we're standardizing it. So with hip flexion, we'll go directly up to his shoulder. And we want to make sure sometimes we're not flaring out, sometimes we're not crossing in, because then when we test and retest, every time it's going to be a little different. So standardized hip flexion, straight up. When we do IR, we keep his knee directly over his hip, and then rotate as far as you can, same thing. Any pinching, popping, pain? If so, where?
Tiny bit, the inside.
Yeah, so a little bit's normal. Anything extreme, we start grimacing or guarding, that's when we want to adjust and keep in the back of our head. Same thing, IR, standardize, hip, knee directly over the hip, rotate, try to find their end feel. Anything there. Okay, we'll do extension facing down, but before that, we'll also get abduction. So keep the knee, just drop it down. Anything there. Okay, we can also do this resisted, pulling up. As you start getting more reps, you'll start to see what a weak adductor would feel like. And then same thing, long lever, pulling in. Okay, so this is more adduction specific, but testing short and long lever, you'll start to find different trends. Facing down. And then extension, we'll do short lever, long lever as well. So first I'll take him passively. Pin his PSIS just to make sure he's not lifting up too much. Anything here? Okay, actively, I'll take him to his end range passively and then go.
Not down.
Anything there?
No.
Okay, so some people might have pain there either in the hip or their back, and then that can help us go down another segment. And then actively, knee bent, lift up. And then passively, knee bent, or passively, leg straight. Actively, lift up. Anything there?
No.
Okay, so quick and dirty assessment, we have 6 actions: flexion, extension, ER, IR, adduction. If we want to do abduction, we can. Almost everyone you're going to be able to beat. They're going to have some type of weakness. But if we want to get that information, we get short lever and long lever on your side, facing that way. So if we want to get short lever, keep your knees bent. Hips stay stacked over each other. Ankles are touching. Just lift the knee up. You're going to do a hold, or we can just get any idea where they're at. Concentric, eccentrically, down and up. Okay, and then long lever, same thing. His hip will stay stacked, knees straight, kick back, lifting up. So it really doesn't matter how strong you are. I'm probably gonna be able to beat you in this position. That doesn't mean it's a top priority of things that need to be addressed, but it is something that we can put in our interventions moving forward.
And if your patient had any radicular symptoms throughout this, would you change your
For sure,
assessment?
for sure.
And
Yeah.
how would you change it?
Depends what positions are painful. So if they have pain with extension versus pain with flexion, it's going to be
This
a very different intervention. That's the point of finding this. So if someone has radicular pain and extension makes them feel better, then I know my interventions are going to be extension based. If someone has radicular pain and for whatever reason flexion makes them worse, whether it's hip flexion, trunk flexion, then that's going to help guide my treatment. But that's the point of doing this, is to find what movements are impaired or have pain, and then adjusting your interventions based off that.
So how about if they have the pinching here, and then also, well, sometimes I have a client that has this. When they let their knee down, they'll feel like a block or something here.
Yeah.
Where do you go from there?
So if flexion and ER are painful,
Yeah, here and this.
yeah. So those would be our 2 things in the back of our head. We know range of motion wise, flexion and ER. And then all of our interventions are going to be towards improving those positions. For the sake of standardization, I usually do ER here, but it plenty of people also go from this position or here. And then you could just take your hands and assess the range of motion like that. That's fine. There's not one right or wrong way. This is just how I do it. I can get the whole thing done in less than a minute and have a pretty good idea of where their range of motion's at. But we'll get into other videos, different interventions for different restrictions. If you have flexion, hip flexion intolerance, then we're going to want to do a lot of mobilizations for hip flexion. If IR is limited, we'll do it to improve IR. If ER is limited, we'll do it to improve ER. And that's like that for every joint, every action. Anything else?